descent. After full cervical dilation, voluntary bearing down helps expel the infant from the uterus and out through the vagina. The maternal position is the actual position the client assumes for labor and birth. During labor, the upright position is the most helpful for bringing the baby down through the birth canal. For pushing the baby out, a semi-recumbent position is typical. Finally, be aware that your client's psychological responses can have a direct effect on how her labor progresses. Since labor and birth are both exciting and anxious times, her stress levels can evoke physiologic responses that might interfere with labor and jeopardize fetal well-being. To summarize, 5 critical factors influencing labor are the passenger, which is the fetus, the passageway, the bony pelvis, and powers, meaning contractions and bearing down, the maternal position, and the client's psychological response. True versus false labor. What is the difference? During true labor, your clients will experience regular contractions that gradually become stronger and closer together. She will feel the pain of true labor in her lower back, and it will move forward across her lower abdomen. True labor does not stop with intravenous hydration or comfort measures. Her cervix will dilate and efface, and as the cervix dilates, she will pass what is called a bloody show vaginally and feel the baby moving down into the birth canal. With false labor, contractions are usually irregular, although they can be regular for short periods. Walking and other activities will stop false labor, as will comfort measures and hydration. And of course, with false labor, the cervix does not dilate and it does not efface. Let's summarize those differences. True labor: progressive cervical effacement and dilation, regular contractions that increase in frequency and duration, pain in the lower back moving around to the front, pain unrelieved with ambulation. Now with false labor, you have no intensifying of contractions, no cervical changes. When true labor does begin, several signs are apparent. The contractions become more frequent. The cervix softens and begins to dilate. The client passes what's called a bloody show. The amniotic membranes rupture. The client has a burst of energy, and she may develop indigestion or diarrhea. The process of labor is divided into 4 stages. The first stage, the dilating stage, has 3 distinctive phases: latent, active, and transition. The first, or latent phase, is the time when the client experiences feelings of excitement as the labor begins. Her contractions are 15 to 20 minutes apart and last 20 to 30 seconds. The cervix dilates from 0 to 4 centimeters. This takes an average of 9 hours in a prima gravida and 6 in a multigravida. During the latent phase, medications are not administered because they might slow down the progress of labor. Walking is encouraged at this time because activity tends to intensify the contractions. The second, or active phase of the first stage begins when the cervix is 4 centimeters dilated and ends when it is 8 centimeters dilated. Contractions are 2 and 3 minutes apart and last 60 seconds. The client feels increasing discomfort during this phase, and her membranes may rupture. The last phase of dilation is transition. This is a very intense time, with contractions coming every minute and a half to 2 minutes, and lasting 60 to 90 seconds. The cervix progresses to full dilation, which is 10 centimeters. Discomfort becomes extreme, and the client might have a strong urge to push, even if her cervix is not fully dilated. She is tired and might be restless and agitated as well, and your support is vital at this crucial time. The second stage of labor is the expulsion stage, and it is the most dangerous for the fetus. This stage begins with a full cervical dilation and ends with the birth of the baby. Contractions are very intense and frequent. The third stage of labor is the placental stage. It begins as soon as the fetus is delivered and ends with the expulsion of the placenta. The placenta begins to detach within 5 minutes of delivery and is usually expelled within 30 minutes. The fourth stage is the recovery stage. the first 4 hours after delivery of the placenta. During this time, your client is undergoing many physiologic adjustments and bonding activities begin. How can you help with pain management during labor? Every client giving birth experiences pain, but many variables influence the degree of pain. Some are physical and include fatigue, fetal size, and position, while others are psychological and include the client's response to pain and her fear of pain. Ingrained sociocultural expectations can affect her personal perception and responses to pain. The environment for labor also affects pain because high noise and activity levels tend to heighten anxiety and fear. The cycle of pain is referred to as the fear-tension-pain syndrome. Your client's responses to pain will change as her pain changes. As pain increases, so do fear and anxiety, and that becomes a vicious cycle when you have an anxious client, as she will have heightened perception of a painful stimuli. Fear, tension, pain can make her hyperventilate, cry out, writhe, scream, and be unable to follow instructions. Not only will tolerance vary among your laboring clients, but so will their expression of pain. Non-pharmacologic measures provide the comfort without the use of analgesics or anesthesia. These include paced breathing, acupressure, visual imagery, therapeutic touch, relaxation techniques, and transcutaneous electrical nerve stimulation, or TENS. You can provide help to relieve the pain in labor and promote comfort by helping your client take a shower, offer soothing physical touch using back rubs and back support, distracting your client with music, television, or talking on the phone, reinforcing breathing and relaxation techniques, and suggesting hydrotherapy, frequent positioning, squatting, sitting, and rocking. Many women prefer pharmacologic pain management, of which there are 3 types: systemic, regional, and general. Systemic analgesics decrease the sensation of pain or pain perception without a loss of consciousness. Although they often reduce maternal anxiety, systemic medications like opioids and sedatives do not always provide adequate pain relief and can cause nausea and vomiting. Plus, they can also cross the placental barrier by simple diffusion. So given within 4 hours of delivery, they can cause central nervous system and respiratory depression in the newborn. The narcotic antagonist, naloxone or Narcan, might have to be given to the infant to reverse neonatal narcosis. Occasionally, barbiturates such as secobarbital or Seconal are used to relieve anxiety and induce sleep in prodromal or early latent labor.